Occupational English test. Listening test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now, look at the notes for extract 1.
Extract 1. Questions 1 to 12.
For questions 1 to 12, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes. Hello, doctor. Good morning.
Good morning. What's your problem?
Well, doctor, I have itchy red rash on my feet.
Okay, what's your age?
21, doctor.
Tell me if you have developed any associating symptoms or signs.
It is tingling persistently, doctor.
Since how long have you had this problem?
For the past 4 weeks.
Exactly on which part of your foot you are getting this problem?
Right great toe, right second toe, right third toe, and right fourth toe. Often the onset of itching starts after removing sweaty socks.
Do you drink or smoke?
I do not smoke, but I do drink.
Have you had any diseases in the past?
Well, I had chicken pox and frequent ear infections.
You had any surgeries as well?
I have surgical ear tubes.
Do you take any medications?
No, doctor.
Are you allergic to any medicine or substances?
Well, I get a severe rash when I access adhesive tape.
Any of your family members have any history of illness?
My paternal grandmother is having cataracts, and my maternal aunt has migraines.
Well, your physical examination reports show blood pressure 110/64, respiratory rate is 18, heart rate is 66, and temperature is 98.6. Lower extremities is warm to cool, proximal to distal. The dorsalis pedis artery pulse palpable bilateral. Posterior tibial artery pulse palpable bilateral. No edema observed. Varicosities are not observed. Right great toe, right second toe, right third toe, and right fourth toenail show erythema and scaling. Muscle strength is 5 out of 5 for all groups tested. Muscle tone is normal. Inspection and palpation of bones, joints, and muscles is unremarkable. You have developed tinea pedis, a fungal culture of skin from right toes. KOH test shows no visible microbes. I'm prescribing Lotrimin AF 1% cream to apply 4 times a day, and Griseofulvin 250 milligrams PO once in 8 hours for 4 weeks.
Extract 2. Questions 13 to 24. For questions 13 to 24, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
You hear a doctor talking to a patient.
Hello, good morning, doctor.
Good morning. Be seated. What's your problem?
Well, I have uncontrolled blood pressure, doctor. Very recently I had a cesarean section delivery.
Okay. What's your age?
36, doctor.
Do you have any chest pain or shortness of breath?
No, doctor, but I have fatigue. Yes, I get tired soon.
You had any previous illness or surgeries?
I have the history of hypertension, gestational diabetes mellitus.
Do you smoke or drink?
No, doctor.
Do you have any family history of coronary artery disease?
No, doctor.
Okay. What medications are you taking?
Cardizem and metoprolol were discontinued. Started on hydralazine 50 milligrams thrice a day and labetalol 200 milligrams twice a day. Hydrochlorothiazide and insulin supplementation.
Are you allergic to any medications?
No, doctor.
Well, your physical examination report shows pulse of 86, blood pressure 175 over 86, afebril, and respiratory rate 16 per minute. Neck veins are flat. Your echocardiogram shows sinus tachycardia and non-specific ST changes. Bun and creatine within normal limits. You have preeclampsia, status post-delivery with cesarean section with uncontrolled blood pressure, borderline gestational diabetes mellitus. I'm ordering echocardiogram for assessment of left ventricular function. I am prescribing labetalol and hydralazine to see the improvements, and based on the response to these medications, I will make further recommendations for your treatment.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you will hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare environment. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You will have time to read each question before you listen to the audio. Complete the answers as you listen to the audio. Now, look at question 25. You hear a discussion about different types of kidney cancers. Now, read the question.
Hello, doctor. Can you brief me about different types of kidney cancers?
Well, like any other cancer, kidney cancer starts when the normal cells in one or both kidneys mutate and grow aggressively, forming a tumor or mass, which can be benign or malignant. Kidney cancers that have originated elsewhere and metastasized to the kidney are clear cell adenocarcinoma, transitional cell carcinoma from the bladder, renal lymphoma, inverted papilloma carcinosarcoma, teratoma, and carcinoid tumor of the renal pelvis. Renal cell carcinoma is the most common type of kidney cancer that accounts for 80 to 85% of all cases. This develops within the microscopic filtering systems of the kidney, which are the tiny tubes that carry the urine to formation. Transitional cell carcinoma, also known as urothelial carcinoma, usually begins in the area where urine collects before moving to the bladder. Pathologically, this cancer is similar to bladder cancer and is treated like bladder cancer. Kidney sarcoma is a rare form of kidney cancer that is usually treated with surgery and chemotherapy. Sarcomas may be large and usually does not spread. Wilms tumor is a common type of kidney cancer that occurs among children and is treated differently than kidney cancers in adults. Common treatments for Wilms tumors are radiation therapy and chemotherapy. Squamous cell carcinoma, juxtaglomerular cell tumor, or rhinanoma, Bellini duct carcinoma, mesoblastic nephroma, mixed epithelial stromal tumors, or other types of kidney cancers. Question 26. You hear the discussion between two doctors about types of perforations during endoscopic retrograde cholangiopancreatography. Now, read the question.
Doctor, can you explain the types of perforations during endoscopic retrograde cholangiopancreatography?
Well, although perforation is an unusual complication of endoscopic retrograde cholangiopancreatography, the diseases of the duodenum and common bile duct can increase the risk of perforation during endoscopic retrograde cholangiopancreatography. There are 4 types of perforations during endoscopic retrograde cholangiopancreatography based on etiology and site of perforation. Type 1 is perforation of the lateral or medial duodenal wall caused due to excessive pressure from the endoscope or its acute angulation. Type 2 perforation is periampullary injury, often associated with sphincterotomy or difficulty accessing the biliary tree. Type 3 perforation is injury to the common bile duct or pancreatic duct caused by instrumentation. Type 4 perforation is the presence of retroperitoneal free air with no evidence of actual perforation. This is usually an incidental finding and is of little or no clinical consequence. Question 27. You hear a discussion between two doctors about clinical manifestations of alpha-1 antitrypsin deficiency. Now, read the question. Hello, doctor. What are the clinical manifestations of alpha-1 antitrypsin deficiency?
Well, alpha-1 antitrypsin deficiency is associated with two major clinical manifestations: emphysema, resulting from the loss of the proteolytic protection of the lung by alpha-1 antitrypsin, a toxic loss of function. Other clinical manifestations of alpha-1 antitrypsin deficiency include pancreatitis and an association with cytoplasmic antineutrophil, cytoplasmic antibody positive vasculitis.
Question 28. You hear a discussion between a doctor and a nurse about autoimmune liver disease. Now read the question. Hello, doctor. What are the autoimmune liver disease?
Well, autoimmune hepatitis, primary biliary cirrhosis, and primary sclerosing cholangitis are the three most common forms of autoimmune liver disease. Autoimmune hepatitis is characterized by high levels of serum alanine aminotransferase and aspartate aminotransferase, whereas primary biliary cirrhosis and primary sclerosing cholangitis are associated with predominant elevations of alkaline phosphatase, since they are cholestatic disorders. Primary biliary cirrhosis and autoimmune hepatitis are associated with autoantibodies in the serum, such as anti-nuclear antibody, smooth muscle antibody, and anti-mitochondrial antibody. Primary sclerosing cholangitis usually affects the extrahepatic biliary system. Thus, if it is present, abnormalities can be seen on imaging.
Question 29. You hear a discussion about brain chemicals involved in mood regulation. Now read the question. Hello, doctor. What are the brain chemicals involved in mood regulation?
Well, basically there are three molecules, chemically known as monoamines, that are involved in mood regulation. Serotonin has been coined the brain's feel-good chemical. Norepinephrine is another neurotransmitter connected with depression and how alert the feelings are. A low level of norepinephrine is considered to be associated with the brain fog that many people with depression experience, whereas low levels of dopamine in a part of the brain called the substantia nigra associated with Parkinson's disease. But there is much more to dopamine. In the frontal lobes of the brain, it is associated with complex thinking and problem solving. In fact, it is considered that the stimulatory effects of chemicals such as nicotine and cocaine are related to their effects on the dopamine-mediated reward centers in the brain.
Question 30. You hear a discussion about different types of gastric juices. Now read the question.
Hello, doctor. What are the different types of gastric juices?
Well, the food we swallow mixes with gastric juices secreted by special glands in the lining of the stomach. They include the cardiac glands at the top part of the stomach, the oxyntic glands in the main part of the stomach, and the pyloric glands in the antrum or lowest part of the stomach. Therefore, each of the glands contains cells that produce specific components that are called the gastric juices. Neck cells produce bicarbonate and mucus. Parietal cells generate hydrochloric acid. Chief cells produce pepsinogen, and enteroendocrine cells generate various hormones. Hydrochloric acid is a strong acid secreted by the parietal cells, and it lowers the pH level of the stomach to around 2. Hydrochloric acid converts pepsinogen into pepsin and breaks various nutrients apart from the food we eat. It also destroys bacteria that comes along with the food. Gastric lipase is another digestive enzyme made by the chief cells. It helps break down short and medium chain fats. Amylase is also found in gastric juices, but it isn't made by the stomach. This enzyme comes from saliva and travels along the bolus into the stomach. Amylase breaks down carbohydrates but doesn't have much time to work on the stomach because the acidity stops it. Intrinsic factor is secreted by the parietal cells and is necessary to absorb vitamin B12. This is essential for healthy nervous system function and blood cell production. Finally, the gastric juices contain water and mucus. The mucus is secreted by the neck cells and helps coat and protect the stomach lining from the acid environment.
This is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about specific aspects of their work. For questions 31 to 42, choose the answer, A, B, or C, which fits best according to what you hear. Complete the answers as you listen to the audio. Now, look at Extract 1. Questions 31 to 36. You hear the lecture given by a senior surgeon on the role of diabetes in the end-stage renal disease. You have 90 seconds to read questions 31 to 36. Role of diabetes in the end-stage renal disease. Of late, diabetes has become the primary cause of end-stage renal disease worldwide. This is due to the fact that diabetes, especially diabetes type 2, is increasing. Approximately 45% of new patients receiving dialysis in the U.S. are diabetic. Early diagnosis of diabetes and early intervention are crucial to prevent the progression towards renal failure, seen in a significant percentage of type 2 diabetic patients and in many type 1 diabetics. The presence of microalbuminuria is the early clinical evidence of diabetic neuropathy, defined as the appearance of low but abnormal levels of albumin in the urine. The characteristics of diabetic neuropathy are a decline in glomerular filtration ratio, progressive increase in proteinuria, hypertension, and a high risk of cardiovascular morbidity. Therefore, the evidence of microalbuminuria should trigger diagnosis for possible vascular diseases and aggressive intervention to cope with all cardiovascular risk factors in diabetics type 1 and 2. The natural history of diabetic neuropathy progresses slowly over the years. In type 1 diabetes, microalbuminuria occurs after 5 years, and the end-stage renal disease develops in 50% of type 1 diabetics. whereas type 2 diabetics has a more variable course. Very few patients with microalbuminuria progress to advanced renal disease. Without intervention, approximately 20% of patients of type 2 diabetes develop an end-stage renal disease. However, due to the increased number of type 2 diabetes patients compared to type 1 diabetes, the maximum number of patients on dialysis are type 2 diabetics. There are many factors which account for the pathophysiological of diabetic neuropathy. Primarily anatomical and structure changes in the kidney result in increased glomerular capillary pressure in diabetes, which is associated with hyperfiltration at the glomerulus. The next factor is the glucose that can increase the formation of advanced glycosylation end products by inversely binding to proteins in kidneys and circulation. Over the years, these formed advanced glycosylation end products, which stimulate the growth in fibrotic factors, contributing to overall renal damage. Thirdly, angiotensin II contributes to the advancement of diabetic neuropathy by narrowing the efferent arteriole in the glomerulus, subsequently resulting in higher glomerular capillary pressures. While diagnosing diabetic neuropathy, early investigation of glucose intolerance in diabetes to distinguish patients who are at risk for developing microalbuminuria is suggested, especially if they have other risks for type 2 diabetes, such as lipid central obesity, abnormalities, or hypertension. Therefore, the investigation of microalbuminuria presence should be performed at diagnosis in patients with type 2 diabetes, whereas in patients with type 1 diabetes, since microalbuminuria rarely occurs with short-term type 1 diabetes, the diagnosis should begin after 5 years of disease. According to the findings, the microvascular complications develop during the prepubertal period of diabetes. Therefore, clinical judgment should be demonstrated when individualizing these suggestions. The object of diabetic neuropathy therapy involves multi-clinical approaches. Tight glycemic control is the keystone in the prevention and management of diabetic neuropathy. The United Kingdom Prospective Diabetes Study and Diabetes Control and Complications Trial have established that an intensive diabetes therapy can considerably decrease the risk of microalbuminuria and neuropathy development. Nonetheless, blood pressure control is another keystone in prevention and treatment, in addition to glycemic control. The significance of blood pressure control, irrespective of what agent is used, cannot be emphasized enough in diabetes, both for slow progression of neuropathy and for preventing cardiovascular morbidity. According to the recent Joint National Committee guidelines, blood pressure in diabetics is reduced to less than 130/80 mmHg. It is very crucial for doctors and patients to understand early on the 3 or more agents. Angiotensin receptor blockers or angiotensin converting enzyme inhibitors are considered first-line agents in patients with concomitant hypertension and diabetes. Diuretics might be added as a second-line agent in many cases after angiotensin blockade in diabetes. Dihydropyridines, a class of calcium channel blockers, may be considered as the third or fourth-line agents in diabetics, only after initiation of angiotensin blockade and diuretics. There are also other non-pharmaceutical suggestions, such as dietary restriction of protein intake, restrictions of protein to 0.8 grams per kilogram weight per day in patients with overt neuropathy, or even 0.6 grams per kilogram weight per day is recommended in the case of declining glomerular filtration ratio. Moreover, it is very essential to stick to a low-sodium diet in diabetic neuropathy, since many diabetics with renal disease are salt-sensitive. Therefore, restricting salt intake will certainly help in reaching blood pressure goals, with secondary benefits of regression of left ventricle hypertrophy, decreased stroke risk, and reduction in proteinuria. A recommended low-sodium diet of 2.3 grams daily in patients with diabetes and either hypertension or proteinuria. Moreover, avoiding nephrotoxin agents, such as radiocontrast media, nonsteroidal anti-inflammatory drugs, is highly recommended. Last but not least, annual diagnosis of microalbuminuria in diabetics will allow the detection of neuropathy at an early stage. Improved glycemic control and intensive anti-hypertensive treatment will ultimately slow down the progression of diabetic neuropathy.
Now look at Extract 2, questions 37 to 42. You hear the discussion of a physician with junior doctors on different types of hernias. You have 90 seconds to read questions 37 to 42.
Hello, doctor. Could you please explain to us about different types of hernias?
Well, inguinal hernias are located in the lower abdomen just above the leg crease, adjacent or near the pubic region. At times, they can also occur on both sides of the pubic area, which is called bilateral inguinal hernias. Inguinal hernias, along with femoral hernias, make up the two types of groin hernias and can cause pain that extends into the upper thigh or scrotum. Inguinal hernias can be categorized as direct or indirect. An indirect inguinal hernia occurs due to natural weakness in the internal inguinal ring, while a direct inguinal hernia caused due to the weakness in the floor of the inguinal canal and is more likely to develop in men above 40. The floor of the inguinal canal is located just below the internal inguinal ring. When inguinal hernias are repaired using the tension repair technique, recurrence rates may be more than 15%. However, other techniques used for hernia repair, such as tension-free and laparoscopic tension-free, have much lower recurrence rates of just 1%. A sportsman's hernia is a condition of chronic exercise-related suprainguinal groin pain. Generally, it involves a direct inguinal hernia. Femoral hernias, along with inguinal hernias, are groin hernias, which are very common in women but can occur in men as well. A weakness in the lower groin makes the intestinal sac to drop into the femoral canal, a space near the femoral vein that carries blood from the leg. These hernias are highly prone to develop incarceration or strangulation as an early complication. Incisional hernias appears in the abdomen at the site of a previous surgery that can appear weeks, months, or even years after a surgery and can vary in size from small to very large and complex. Umbilical hernias appear near the belly button or navel due to a common weakness from the blood vessels of the umbilical cord. This may occur in infants at or just after birth and may resolve by 3 or 4 years of age. However, in adults, umbilical hernias will not resolve and may progressively worsen over time. Epigastric hernias are more common in men than women. They occur due to a weakness or opening in the muscles or tendons of the upper abdominal wall on a line between the breastbone and the navel or umbilicus. Spigelian hernias, a protrusion of intestine or an empty sac through a weakness between the muscle fibers of the abdominal wall, often on the right-hand side of the abdomen. It becomes impossible to detect because often there is no obvious swelling or lump. It develops between the muscles of the abdominal wall rather than protruding through layers of fat. It often develops in later life of men and women when the abdominal muscles become weaker. Hiatal hernias are slightly different from other types of hernias because they are a weakness or opening in the diaphragm that separates the chest cavity from the abdominal cavity. These hernias cause reflux of acid from the stomach into the esophagus, resulting in heartburn, pain, and erosion of the esophagus.